All right, I have about 6:05. It's time to begin. I'm going to go a little bit longer tonight than I normally do, but that's because there's some new data that I wanted to share with you all. Um, my name is Daniel Southern. The name of my practice is Interventional Orthopedics CT, and we're located in Norwalk, Connecticut. I am a fellowship trained physiatrist, board certified in physical medicine rehabilitation, sports medicine, and pain medicine. I started doing regenerative orthopedics, interventional orthopedics, about 8 years ago or so. So I've had some experience in this field. And that's what we're going to talk about tonight. Let me share my screen and we will get going. So, the title of this evening's presentation is Sports Injuries and Arthritis, How to Avoid Surgery. I want to start with an introduction to the field of interventional orthopedics, basically go through its recent history, discuss some examples, and then get specifically into some data regarding shoulder and knee. For historical purposes, in 2005, for the first time on Earth, medical doctors began treating orthopedic conditions using precise stem cell injections. And what this did was begin a new field of medicine. And this new medical specialty is known as interventional orthopedics. What does that mean? Well, the best way to describe that is probably to compare it to traditional orthopedics. And in traditional orthopedics, they are using scalpels, drills, and saws as their tools. They are incising, cutting, grinding, amputating. They're placing screws, plates, rods, nails, anchors, staples, and sutures. In other words, a lot of hardware. The metaphor here is one of carpentry. Compare that to interventional orthopedics, regenerative orthopedics. What we're doing is we're using only needles and advanced imaging. This is a real-time X-ray known as fluoroscopy and ultrasound, which is bouncing sound waves off of tissues. So no radiation there. All we're doing is injecting. What are we injecting? We're injecting our patient's own blood and or cells. We are delivering growth factors to damaged tissues. The metaphor here is one of gardening. In traditional orthopedics, what they are doing is they're removing and rearranging tissues. They are deconstructing, reconstructing tissues, and replacing native structures. In interventional regenerative orthopedics, we are attempting to stimulate the repair and regrowth of tissue. We are preserving native structures, and that difference is key because whenever you alter the native structure or the design of the human body, that comes at a cost. We will discuss that more as we go along. I'd like to jump now to the traditional algorithm of treatment in any orthopedic office in the country. Let's talk about just musculoskeletal injury. Begins with an injury, and most injuries will respond to acute triage, meaning you rest it, maybe you take an ibuprofen. If you're smart, you put some ice on it, and it gets better. When it doesn't, you call up your primary care doc, and he says, well, you're not better. I don't think it's serious, but let's go to rehabilitation. Let's go to physical therapy. So you go to physical therapy, and the majority of patients will respond to physical therapy in time, and they're better, and that ends the issue. However, when it doesn't end the issue, you go back to the primary care doc, and he says, well, why don't we try a steroid injection? He does a steroid injection. That may or may not help. And if it doesn't, he may send you on to the orthopedic. The orthopedic says, well, you've done the steroid injection, you've done physical therapy, it's time to get the MRI. Well, if you're standing in an orthopedic surgeon's office and you get an MRI, your chances of having surgery go up about 90%. Surgery tends to lead to more surgery, and over time, a couple of surgeries and a decade or two later on the joint that was bothering you, you're a candidate for total joint replacement. This in rough is the algorithm of treatment of joint pain in orthopedics of America today. So what's wrong with the traditional algorithm? Well, first off, steroid injections. Why are they bad? Well, because steroids are toxic to tissues. You cannot grow anything if you add steroids to the petri dish that you're growing that substance in. There was a famous study done in Journal of American Medical Association, came out in 2017. It studied a standard steroid known as triamcinolone acetate, 40 milligrams. The study was injecting arthritic knees every 3 months for 2 years. They randomized patients to get a steroid injection or an injection with normal saline. And after 2 years, they did a follow-up MRI. And what do you think they found? They found 50% cartilage loss in the knees receiving steroid injections every 3 months for 2 years. Steroids does terrible, terrible things in the body, weaken ligaments, they lower bone density, they raise your blood sugar, suppress the immune system. And they're very, very toxic. They kill the very cells in a painful joint that we are trying to keep healthy. The local anesthetics that we inject steroids with, bupivacaine especially, as well as lidocaine, which are the most commonly used local anesthetics, these are, if anything, more toxic than steroids to the cells that live inside your cartilage, the cells that live inside your ligaments, the cells that live inside your tendons. So just generally, a steroid injection, particularly repeated steroids over time, really bad idea. What's wrong with the current algorithm? Meniscectomy. This is also known as the, your knee is bothering you, it's got arthritis, let's go in and clean it up. So this is an arthroscopic clean up the arthritis surgery. The literature is quite clear on this. It should not be done. Why is that? Well, because even the most minimal clean up the arthritis surgery increases your risk of developing arthritis in that joint threefold over the course of perhaps 8 years. This is a study done by Stein in 2010. When they go in and repair a meniscal tear in your knee, they don't actually repair it. They do try to do that in their younger patients, but most older folks, they just get what's known as a meniscectomy, meaning they just remove large sections of the meniscus until the tear can no longer be seen. And what they're doing is removing cushioning in the knee joint. And if you do that, you increase loading forces. And if you increase loading forces, you accelerate degeneration in the knee joint. So in general, meniscectomy, the clean up the arthritis surgery, it's not good, not a good idea. What's wrong with the current algorithm? Knee ligament repair. The traditional ACL repair. This is a treatment that orthopedics are rightfully very proud of. They get professional athletes back on the field after they have torn an ACL. Unfortunately, they don't get them back for very long because there is a problem with ACL repair, as good as it is. They actually don't repair the ligament. They cut out what remains of your native ligament, and they replace it with a graft that they take from another part of your body or tissue from a cadaver, a dead man. The problem with that is that the angle of the native ligament cannot be reproduced. It's very, very steep, and what they have to do is replace it at a much more shallow angle because they have to drill in from the back of the thigh bone and the front of the leg bone and place this thing, and it's a much steeper angle than the native ligament that they have cut out. Well, the problem with that is we think is that it creates a different type of instability in the knee, which over time, without a doubt, destroys the knee. This is an article from the New York Times published in 2017, noting that ACL repair in teenagers was soaring. It also noted that the most recent finding was that 50% of these adolescent patients will develop knee arthritis within 10 years of the repair of their ACL. In other words, there's something about the ACL repair that creates a different type of instability, which over time destroys the knee. So you've got adolescent athletes who in their mid to late 20s suddenly have a knee that is that of a 60-year-old person, and it needs replacement, but they're in their mid to late 20s. You can't quite do that. The article ended with the question, will surgical techniques that more closely resemble native anatomy reduce the risk of knee degeneration following ACL repair? And the answer to that most likely is yes. Back to the current algorithm, what's wrong with it? Joint replacement. Joint replacement, particularly in knees, is not all that it's cracked up to be. A study done by Harding in 2014 shows that there was minimal functional improvement following knee replacement. And many patients complain of pain following total joint replacement. It's a problematic joint to replace, and as many as 50% of patients have the same or worse pain 3 to 5 years following their replacement. And finally, there's a risk of metal and material fragmentation from the prosthesis that's placed into the knee, which creates its own problems and, of course, pain. What is the promise of interventional orthopedics? Well, the promise is that we are using the body's ability to heal itself. And that takes training to do. We have to know how to harvest or repair hormones and cells, concentrate them, and then very precisely place them into areas of damage. The promise of interventional orthopedics is that it's minimally invasive. It reduces or eliminates operative trauma. The recovery is minimal with very limited post-procedure recovery. And it's a far, far less painful rehabilitation back to complete recovery. And most importantly, finally, it preserves native tissues. Again, we are not altering the native design of the human body. And that's quite important. There's just a huge bonus to being able to do that. Here's a schematic that illustrates the healthy balancing act inside of any joint in the body. There's a balancing act between forces that degrade the joint and forces that cause repair in the joint. The degradative forces are catabolic and pro-inflammatory. The repair forces are anabolic and anti-catabolic. What we're trying to do is keep a balance. Let's say that you have an injury to this joint, and that creates some instability, which over time will destroy the joint without a doubt. An unstable joint is a joint that's definitely going down. Let's say you put on a few pounds with age, you gain extra weight. This increases loading forces, which also accelerates degeneration in your joint. If you're a smoker, without a doubt, the oxygen radicals created in the body by smoking serve as a wrecking ball for articular cartilage and joints. You're not eating really well. You're eating pro-inflammatory diets, contributing to greater inflammation in the joint. You're not very fit. That also contributes to degeneration in the joint, and as does a sedentary lifestyle. If any or all of these things are happening to you, what you're doing is you're just roughly increasing the forces that degrade the joint, and you're tipping the balance towards degeneration in your joint. So what do we do to counterbalance, to counteract these forces? Well, we focus on forces that are anti-catabolic. Catabolic is a word that means breakdown. So we're looking at forces that prevent breakdown. What are some of those? Well, these are chemicals that have been recently discovered in human blood products, all of them, within the past decade or so. And these chemicals counteract the pro-inflammatory environment inside a painful joint. They inhibit things called MMPs and peptidases. These are small enzymes that are actually digesting your cartilage. And when we inject blood products into a joint that is undergoing this destructive environment, we change that chemical microenvironment rather rapidly. Some of these substances are known by fancy names such as interleukin receptor antagonist protein, otherwise known as IRAP, alpha-2 macroglobulin, A2M, TIMP, tissue inhibitor of metalloproteinases. And like I say, these are all found in human serum. Other factors that we use are anabolic. That's a word that means to build up. And these basically are growth hormones. And growth hormones are powerful cell signaling molecules that promote healthy cells and cell division and growth. They increase vasculature. They stimulate protein and matrix secretion for increased and more vibrant cartilage and cartilage repair, as well as repair of tendons and ligaments. Some of these substances are known by the initials PDGF, which stands for platelet-derived growth factor. FGF is fibroblast growth factor. VEGF is vascular endothelial growth factor. Where do we find these factors that tip the seesaw towards repair in any painful joint? Well, we find them from our patients, and we call these autologous, which is a fancy word for self. These autologous repair tissues are known as orthobiologics, and that comes from using a patient's biological tissue to treat orthopedic conditions, orthobiologics. What we do is first we have to harvest them from our patients in a non-painful fashion. And then we use them by placing them very precisely into areas of damage in the body. Repair tissues come in two forms in the human body. One is a small circulating blood cell known as a platelet. You may have heard of platelet-rich plasma. And this is a preparation of your platelets that we use to treat small tendon and ligament tears and early to moderate osteoarthritis in joints. The other is an adult stem cells. Now, we find adult stem cells in every biological tissue niche in the body, but for our purposes, we focus on the stem cells found in bone marrow. So let's go back to the balancing act schematic here. Let's say you come into my office and you have some early form of arthritis, maybe a little bit of instability, and I look at your MRI and do an exam and decide, well, I think a platelet-rich plasma injection will be helpful. Well, what happens when we do a PRP injection? Well, what we get is a whole host of anti-catabolic factors, those chemicals that I just talked about earlier, that immediately change the chemical microenvironment inside a degenerated joint and turn a degenerated chemical environment into a pro-growth, pro-health environment. The other thing we get is PDGF. This is one of these growth hormones, platelet-derived growth factor, very powerful, stimulating the repair, the growth of repair cartilage, repairing small tears in ligaments and in tendons, should you have them. But what if you come in with later stages of osteoarthritis, or you come in with an ACL tear or a medial collateral ligament tear in the knee? I may recommend that we do a stem cell injection, which is otherwise known as mesenchymal stem cell injection, MSC. Well, what do we get with that? Well, we get a whole host of very powerful growth hormones, VEGF, FGF, IGF, CXCL. And what we've done by doing this, treating your joint with orthobiologics, which again are your repair cells, we tip the balance towards buildup of the joint, anabolic forces, and we emphasize anti-breakdown forces, and we therefore tip the balance of this seesaw back towards repair and a healthy joint. So let's return to the algorithm now. This is the traditional algorithm we just discussed. It's pretty much the same in interventional orthopedics up until the point of the MRI. At that point, if you're standing in my office and I see something, I think I can help you with that. And I think we need your platelets, or we may need your stem cells, but I'll propose an orthobiologic treatment. And let's say you have that treatment. 2 to 4 weeks later, I'm going to send you back to physical therapy. And when we're successful, the end result is that we have preserved your native tissue and or joint. And most importantly, what we've done is taken you out of this algorithm, which is pushing you inexorably towards surgery in traditional orthopedics. We take you right out at the point of the MRI, so you don't have to worry about being further pushed down this algorithm. We perform precise image-guided stem cell and platelet procedures to treat headaches, neck pain, upper back pain, shoulder arthritis, which includes rotator cuff tears and labral tears, wrist and thumb arthritis, elbow arthritis, low back pain, including radicular nerve pain into the leg, facet syndrome, disc herniation, bulges, and stenosis. Hip arthritis, including hip labral tears. Knee arthritis, including meniscal tears, ACL tears, other ligament, knee ligament tears. Ankle arthritis, ligament and tendon tears. Let's look at some examples of interventional orthopedics. I love this slide. This is an MRI slice through an axial knee. We're looking at this knee from the foot up towards the head, so that would make this the left knee. This is the inside of the knee. This is the outside of the knee. This is your kneecap. This is the distal thigh bone. This gray stuff behind the kneecap is cartilage, and clearly it's breaking up. Why do I know that? Because this bright signal inside the kneecap indicates that some of the white fluid is being forced into the bone. And the bone is now inflamed, edematous, and it actually has, some edema. This is what we call a bone lesion. If this persists, this bone will die. And what you will have is a bone cyst, and it is a pocket of dead bone. So this has to be treated. We have to treat the cartilage. We have to treat this lesion. This shows the setup in an interventional orthopedics office of how this is done. This contraption, of course, this is the knee. Here's the surgeon. This contraption is the C-arm fluoroscope. Again, this is real-time X-ray, taking a picture of this setup. Here's the picture. What you see is a fairly large bone trocar that has been inserted into the kneecap, right roughly into the area where there is a bone lesion. And then you see a smaller needle that goes in between the kneecap and the femur, and there's a thin little black line here. Well, that's contrast that the surgeon has injected, showing that they're actually in what we call the anterior compartment of this knee. Now what he's going to do is he's going to inject bone marrow aspirate concentrated that he has taken earlier from his patient into the bone and over the articular cartilage of the kneecap. This is a picture, real-time picture, actually, of two placements of a needle treating a shoulder. And this happens to be a shoulder slap lesion, otherwise known as a superior labral anterior posterior tear. The first placement of the needle right here, and this dark stuff is dye injected into the glenohumeral joint, which is your shoulder joint. So the shoulder joint is being treated with the first placement. The second placement is right here, and you see that triangle of dye? That's the labrum. This is the precision with which the needle has to be placed to address these issues. This hopefully brings the point home even more. This is what we call a hydrodissection of the median nerve. We're looking at an ultrasound. This is a transducer placed over the wrist in the axial plane. You will see the needle coming in here, and this is the median nerve. And what's happening is a very delicate placement and injection separating the nerve from surrounding soft tissue. For scale, this is the size of a pea. So you see how precise this is. Why will interventional orthopedics replace elective orthopedic surgery? Well, that's because it's less invasive. There is a quicker recovery. And bottom line, we get to preserve your native tissues, which is always, always preferable to replacing them or altering them. So to take a 30,000-foot view here, we're able to help patients with severe shoulder arthritis and rotator cuff repairs by doing this type of work, and we do it without doing surgery. Let's look more specifically now at rotator cuff repair. What's the problem with rotator cuff repair traditionally? Well, the problem is the re-tear rate. This is a study done by Henry back in 2015, and it was what we call a systematic review, rather. It involved looking at 18 studies that reached a certain level of quality, and in total 954 patients. And all of these patients had what was called a massive tear, meaning it was complete or at least a large partial tear of the rotator cuff in the shoulder. These patients underwent surgical repair of this tear and were followed from anywhere from 33 to 52 months. So, 2 to 4 years following the procedure. And what do you think they found? The re-tear rate, in other words, the failure of this repair of the rotator cuff was 79%. 8 out of 10 patients who came in had their repair fail at any time from 2 to 4 years after having done it. And that's an eye-popping failure rate, I have to say. Instead of surgery, what we do is we inject high-dose stem cells precisely into the tears using ultrasound guidance. Here's a schematic of how that looks. This is the transducer, which is bouncing sound waves off the tissue so the doctor can see what it looks like. The surgeon is looking into a monitor, which is showing him. And this is the syringe and the needle that he's placing. And this is basically the subacromial bursa that they're showing here. But right underneath the bursa is the rotator cuff. There was a large case series published in the Journal of Pain and Research in 2015 showing very positive outcomes of treating rotator cuff tears with bone marrow. And there was just a very well done randomized clinical trial completed. This is a randomized clinical trial, which is level 1A evidence, which is the highest form of clinical data that we have in medicine. This involved 49 patients that were followed after rotator cuff repair using the patient's own bone marrow stem cells. All these tears were non-retracted. They were complete tears as well as large partial tears. They compared the bone marrow stem cell treatment to physical therapy. And the patients who received physical therapy were allowed to cross over to the bone marrow treatment arm after 6 months. This is this graph shows the outcome in DASH scores. This is a disability score of the upper extremity. Lower scores are better here. This is a graph of patients treated with physical therapy up to about 6 months post-treatment. And here are the patients treated with bone marrow. You see that their scores are much lower and significantly so. All of these patients, all of them elected to cross over to the treatment arm. And then this treatment arm was followed out to not just 1 year, but 2 years. And at 2 years, what was found was that the improvement was sustained at 2 years in all 3 outcome measures, which included disability, pain, and a single assessment numerical evaluation of their treatment. The majority of these patients had post-MRI studies obtained, and 73% of them, so 3/4 of them, showed definite signs of rotator cuff repair improvement. 3 of these patients were lost to re-injury, and it doesn't say in the study whether this was actually a re-tear of a repaired rotator cuff, but let's assume it was. This would create a re-tear rate of 3 out of 49 patients, or 6%. Compare that to the eye-popping 79% that I just showed you with surgical repair. Quite different. This is just a photo before and after. This is a massive cuff tear. This is the rotator cuff. You see it stops there, and it's all this white. This is the red arrow sign. And this is post-bone marrow treatment. It's black all the way over to the bone. Now it's fully repaired. Again, the 30,000-foot view, we're able to help many patients with ACL tears in the knee or other knee or joint ligament tears. Let's look specifically at knee ACL tears, avoiding ACL replacement. Remember, we talked earlier that ACL replacement led to degeneration of the joint over time, and that 50% of adolescent athletes undergoing ACL repair had a trashed knee within 10 years of the joint replacement. So in other words, the take-home message is if you can avoid ACL replacement and repair, you should. So we can treat these types of ACL tears. We can treat partial tears. We can treat full-thickness, non-retracted tears. If your tear is a full-thickness, retracted more than 1 centimeter tear, we can't help you. And if you come into my office, we'll tell you that. We're not going to try to have you do something that data says we can't repair. So these are the 2 types of ACL repairs, and these, quite frankly, are the majority of ACL repairs. So the majority of ACL tears we can repair. And this is a pilot study done by Centeno in 2015. And this is basically how it's done. This is the position that the patient is placed on the table with this knee elevated. And these are these two pictures here are fluoroscopic images of the ACL being injected. If you look closely, you can see the needles coming in here from the front. And the dark stuff is the dye that we're injecting, showing that we're in the ACL. A pilot study done in 2015 involved only 10 patients, but 10 out of 10 with decreased signal on ACL and follow-up MRIs, with a mean reported improvement of almost 90%. And this was just a pilot study to prove proof of concept that this could be done. Here's an ACL picture of the anteromedial band of the ACL with dye in it. The needle can be represented by this arrow coming in from the front. Here's the kneecap. And this is what the surgeon is looking at when he's repairing an ACL with a needle through the front of the knee. This is what we're looking at. This is a torn ACL, and this is a scale of the grayness within this ligament. The ligament should be nice and healthy and black, but you see, according to the gray scale here, there's a lot of gray in it. This is a knee post bone marrow stem cell treatment. You see how black it is. The gray scale has considerably lessened. This is a study that Centeno did following his pilot study. This was published in 2018, and it's basically a registry data outcome study looking at patients who had undergone this treatment. 77% showed objective improvement at 8.8 months following this treatment. Self-reported was 72% improvement at 2 years. There were significant decreases in pain and function at all time points. Again, 17% of them, 5 out of 29, had surgery. 1 had a re-tear. Compare this to surgical re-tear rates of up to almost 30% in ACL. It's significantly better. And again, this is not surgery. This is a ACL which is completely torn, full of gray, very amorphous, treated with bone marrow. 6 to 8 months later, very consolidated, black, healthy, perfectly normal in appearance. This is one of the before and after type MRIs that we have that are quite eye-opening with this type of work. Knee arthritis, avoiding surgery. This is a study, again, done by Centeno in 2018, and it was very analogous to the randomized clinical trial that he did in the shoulder. He compared bone marrow treatment of knee arthritis with patients just treated with physical therapy. And the patients treated with just physical therapy were allowed to cross over at 3 months. And all of them, of course, did. There were significant improvements in the bone marrow treated patients versus exercise-only groups at 3 months. All these patients crossed over, and at the end of 2 years, all of them showed significant improvements in their outcome measures of pain and functional ability after 2 years. No surgery involved. Knee arthritis, avoiding knee replacement. These are studies done by Ernegau, who was a French surgeon, one of the godfathers of the field of regenerative orthopedics. He is an orthopedic surgeon himself. He published a study in 2021 that was quite eye-opening. He treated 140 patients that had bilateral similar knee osteoarthritis. In 140 of those knees, in other words, 1 knee in each patient, he injected with bone marrow aspirate concentrate that he got from his patient. The other knee was replaced. He did that replacement. He injected the other knee with the patient's bone marrow and then followed them for 15 years. And this is what he found. The failure rate in the knees injected with a patient's own bone marrow was exactly the same as the failure rate in the knee that was replaced with a prosthesis. And that totaled about 1.19% per year in the bone marrow group and 1% per year in the total knee replacement group. The conclusion was that this study showed, without a doubt, that orthobiologic injection using bone marrow aspirate concentrated, in other words, stem cells, had a sufficient effect on pain to postpone or avoid the total knee replacement in the contralateral joint of patients with bilateral knee osteoarthritis. This was a randomized trial with 15-year follow-up. That's just, it's unheard of. You just don't see a study done like this without, they're very, very expensive studies. So when your orthopedic surgeon tells you that the data isn't good on stem cells for knee arthritis, he is incorrect. I want to end with just a little bit about stem cell hype. We live in an age that Dr. Centeno refers to as the wild, wild west of stem cells. And what he means by that is that there are 3 stages of adoption of a new medical procedure. And the first phase is, this is magic. It really works, and it helps everybody. And that was the initial reaction when you first start doing this, and you get some successes. You think, my gosh, this is just wonderful. But you do it for a little bit longer, and you learn a little bit more, and you decide at that point, this is phase 2, hey, this is great. And it helps, well, almost everybody. It doesn't help everybody. If you do it even longer and you collect your data, what you find is that, hey, let's figure out who's a good candidate. My clinic is one of a few in the entire country that's doing this, that is in phase 3. Everyone else doing this is still pretending that this is magic. Well, the take-home message here is that this is not magic. This is a bona fide, studied medical procedure that can be helpful. And as an expert in the field, it would be my pleasure to evaluate you in terms of whether you are a good candidate for this work. Because if you're not, I'll tell you straight up, because I am part of a cadre of physicians who are dedicated to bringing this modality into the mainstream. And as such, I have no interest in injecting you with your repair cells if the data says that you're not a good candidate for this. That concludes my presentation. And now I'm happy to take some questions. Yeah, that was a bit longer than I normally go. I'm sorry if I lost you all. That was a lot of information to cover, and I'm sure I did it very rapidly. But if you have a question, I can't hear you. I don't know if that's a function of my Zoom or what, but you can type in a question and I can see it and happy to answer it. I don't see any questions at the moment, but I'll give you a few minutes. We have a question from Glenn. Do knee injections show benefits for those who had meniscus tears that were surgically removed? Well, yeah, here's the thing, Glenn. Once you have a meniscal tear that's been surgically removed, you've had a meniscectomy. So you are then subjected to the degenerative outcomes that are associated with arthroscopic meniscal removals. So can we help you then? Yeah, we can. But you've started a degenerative cascade with inside that knee if you've had that surgery. And typically what happens is you have wear and tear now in your cartilage, which is on either side of the meniscus. And quite often you have instability in the knee joint, and we can help you with both things. Yes, definitely. In fact, a lot of my knee patients come in after having had meniscectomies, and we treat them. And if you come in early enough, we can, again, take you out of that traditional treatment algorithm, which pushes you towards joint replacement, which is really where you're headed. Once you've had a meniscectomy, you go back 5 years later and, well, let's clean it up a little bit more. Or at this point, gee, I can't do anything but replace the joint, but I'm happy to do that for you next Tuesday. That's typically what happens. In my office, if you come to me, if you've had the meniscectomy and the minute it starts aching again, and you kind of go, oh gosh, I guess it's torn. The meniscus is torn again. If you come to me, yeah, quite often we can help you by using your repair cells to tighten up the joint, get you greater stability, and to see what we can do in terms of reversing the degenerative cascade that's occurring in the joint as a result of that surgery. That's a pretty common scenario. So yeah, we can do that. This is a question from an anonymous attendee. Hi, what factors, quote unquote, qualify or quote unquote disqualify, so to speak, for someone become a candidate for these procedures? A great question. And for every joint, it's slightly different. We know that the outcome data for hips, for example, just is not good. So we have very strict criteria for hips. But typically, if you're over the age of 55 or 60 and you've lost any significant range of motion, those two factors alone sort of say, hey, stem cells are probably not going to work for you. Your chance of responding to stem cells is 30% or less. So that means that every 10 times we try with a joint like yours, 7 out of 10 times we're going to fail. Those aren't great odds. And, I'll tell you straight up about that if that's the category you fall into. And yet I've had some patients who say to me, I want to try anyway. And yes, I have had one or two exceptions. I do give a talk where I show exceptions to all of the criteria, which we consider put you into the fair or good categories for this type of work. And in every joint, there is a poor category. And if you fall into that, we basically say, hey, you really shouldn't be spending the money that it costs to do stem cells because it's probably not going to work for you. But I do a talk where for every joint in the body, I show one or two cases that are exceptions of patients who walked into my office and were poor candidates, and I told them they were poor candidates, and yet they insisted upon trying. We tried, and they had a good outcome with which they were very, very happy. So there's exceptions to all of these rules. Some of the broad candidacy characteristics are stability in a joint. If a joint is so badly arthritic and one bone is actually, sliding off of another, you're probably not a good candidate. But you'd be surprised. Very, very severe forms of arthritic knees fall into our fair to good categories and can be treated, and successfully so, and avoid or very significantly delay needing joint replacement. I should give that talk again about candidacy ratings, and I probably will. So stay tuned. Any other questions? Here's another question from Anonymous. Our stem cell counts decline with age. So why wouldn't harvested stem cells from umbilical cord donors be a better alternative for people over 60? That's an excellent question. And clearly I see that Anonymous has been doing some research, and that's great. That's really great. First off, just to give you a quick overview, and I don't mean to get you deep into the weeds of the federal code of regulations that governs this field. the use of umbilical cord stem cells for anybody other than your own umbilical cord stem cells, which preserved when you were born, cannot be used in this country. You cannot do that. It's not legal. It's not ethical. You can't do that. Theoretically now, in terms of science, theoretically we could inject umbilical cord stem cells into people, but that's illegal in this country, and it's a felony to do, and it's unsafe if you do it with a commercial vendor who claims to be giving you these things, because we have no idea of the purity or the non-contamination of that cell, which is not yours. So theoretically, yes, you're correct. That might be better because absolutely your stem cells do decline with age. And the data in the largest registry we have shows that people who are much older continue to respond to treatment with their own stem cells, despite the fact that that stem cell population has decreased dramatically with age. That's probably for a couple of reasons. Harvesting techniques of bone marrow stem cells have, become much improved, and there is a target cell population that we seek. And that's a study done very early on in this field, again by Centeno, showing that the number to hit was 400 million cells per microliter. That's an important number to hit. And if you're older, I have suggestions when you come into my office of the insurance policies you can take out to hit that mark. And typically we hit it all the time. I can count on one hand the times that we have not, and they're mostly with older patients. But the harvesting techniques have improved, and the Prolon diet is very, very helpful in improving stem cell counts. And we count all stem cell samples that we put into our patients, and we routinely hit the mark of 400 million cells per microliter. Now, you can still get a good result at less than that mark, but the data shows that if you hit that mark, you're going to get your best results consistently. So that's a long-winded answer to your question. People who profess to have umbilical cord stem cells in this country or even out of this country, generally that's a bright red flag that says this is fraud. We're just trying to separate you from your pocketbook. Any other questions? Glenn has another question. Do our bone marrow stem cells reproduce after harvesting? If we harvest an elderly, does it adversely affect healing from injuries? No, it doesn't. And yes, absolutely, your cells are alive and living. We take them out of our subjects, probably in a early in the day procedure. It takes us, anywhere from an hour, 30 minutes to an hour to extract all the cells that we need from the bone marrow. And then we bring you back into the procedure suite and we put them into you. Your cells are alive and healthy. They've been out of the body, but they've been kept at temperature control. They're all viable, approaching 100%. So yes, they reproduce once we put them back inside you. That's the whole point of doing this work. And stem cells are very, very powerful repair cells. So they're immediately in an inflamed environment that we make sure that we have before we put our stem cells into that environment. We always do a pre-injection, and that pre-injection is aimed at creating a low level of inflammation inside of a joint, because your body heals itself through inflammation. And when you put stem cells into an inflamed environment, that's an activating condition. Stem cells and inflammation tells the stem cell they got to get to work. Stem cells then begin to secrete all types of hormones that mobilize other cells to get to work. That summons other cells to the area. Stem cells themselves begin to transform into the tissues that are required. So yes, the whole idea of doing this is to capture your live stem cells, even in elderly patients. Yes, your stem cells are healthy, the ones that are still there, and they're working. Quite often we're transferring them simply from an area where there are a lot of them into an area where there are fewer of them, or the stem cells that are there aren't functioning properly, or into areas that just don't have stem cells, that are torn, they have a poor blood supply, they don't have access to stem cells, and we place them very precisely into those areas, and they go to work doing repair for us without surgery. That's the promise of this field, and that's what we're attempting to do with this type of work. These are good questions, folks, and I appreciate them. Happy to answer any more that you have. Again, from Anonymous, what is the difference in stem cells? What is the difference in stem cells and growth hormones? Growth hormones are contained inside stem cells. Growth hormones are contained inside the other repair cell in your body, which is a platelet. Stem cells have a lot more growth hormone compared to platelets, and a greater variety of growth hormones. And growth hormones can be quite specific. Some, they can be very specific for nerves, or very specific for collagen and cartilage repair, very specific for ligament repair. The reason we use stem cells from bone marrow is that stem cells in bone marrow have a particular propensity to become the tissues that we're interested in: cartilage, ligaments, tendons, and bone. Growth hormones alone are not the same as a stem cell. No. Why? Because a stem cell secretes many other things other than growth hormones. It secretes secretins, cytokines. These are signaling molecules to other cells to tell them to start doing things. So they're technically not growth hormones. I think the reason you may ask that is that some vendors out there who profess to be selling stem cells, exosomes, umbilical cord cells, or whatnot, all of which is fraud. This comes in a little vial that the provider can buy out of the back door of an OBGYN clinic, perhaps. And this stuff has been analyzed. And what has been found is that there's not a single living cell inside this stuff. And that's important, because whoever's vending this stuff realizes that a living cell, it could be quite dangerous to whoever is getting injected with this stuff. So they irradiate this tissue, whatever it is, so that anything that's alive inside it is now no longer alive. And what we found is that there are growth hormones. There are a few growth factors inside this stuff. The quantity and the concentration of these growth factors absolutely pales in comparison to what a trained physician can get from their living patient when they know how to do this. So, the bottom line is, why would you bother with using growth factors that you can buy in a vial as opposed to harvesting them from your patient? There's many answers to that question, but I hope that begins to, at least in the ballpark, show the difference between what a stem cell is and what growth hormones are. They're not the same. They do overlap. Stem cells have and do secrete a wide variety of growth hormones, which are powerful and important to repair, absolutely. But growth hormones alone, no, they pale in comparison to what a stem cell can do when precisely injected into damaged tissues. Another question. Does harvesting stem cells from the hip increase risk of hip injury in the future for the elderly? No. No, the answer is no, it does not do that. We're just making small little bore holes into the back of the hip, which we call the iliac crests. These are very, very thick bones. They contain a lot of marrow. Doctors like me in this space are trained to get bone marrow. We could get that from any bone in the body. We get it from this one area because there's a lot of marrow there. The bones are very thick. We don't have to worry about nerves and blood vessels. We are making, multiple little holes into the bone, but these are bony fractures that, form a callus and are healed and gone within 4 weeks. And it doesn't. They're so small, they are not weakening the pelvic girdle. And we're not actually going into your hip joint, the articular portion, to get your marrow. In fact, we're getting them from the large bones that make up your pelvis, and quite often we're injecting them straight in to the hip joint, where the bone marrow cells, if there are any left there, are not working. And we will inject healthy stem cells from this part of your body into that part. So, long-winded answer, no, harvesting stem cells does not increase your risk of fracture or injury to the hip joint, no. Another question. Can you comment on peptide use as an alternative or in combination with stem cells? I really can't. For the most part, peptides, exosomes, actually what you're getting when you're supposedly injecting peptides and is not real clear. I know peptides are all the rage amongst bodybuilders. I've had several in my office talking about them. I don't have any evidence that peptides are harmful. We don't have any evidence that exosomes are harmful, depending on what exactly they're calling an exosome and where they got it. Could there be some contamination there? Yeah, there might be. So you have to be very careful of that. We're not interested in that because all that stuff kind of pales in comparison to what we're doing as physicians, using our patients' repair cells. You tend to find exosome treatment and peptide treatment being provided by non-medical physician practitioners, chiropractors, therapists of various types, because they don't have the training or the skill to get patients' repair cells. So, again, long-winded answer, I can't really answer that. We're not interested in them. We don't use them because we don't feel we need them. We feel we're getting all we need from our patients in front of us. And again, that takes a lot of training. Great questions, folks. Great questions. I really appreciate them. Happy to stay on a little bit longer and answer any more that you have. Again, let's see, we've got another question here. Again, from Glenn, where is your clinic? Again, Glenn, my clinic is in Norwalk, Connecticut, 91 East Avenue, Norwalk, 06851. I should share the screen and put that back up here. So yeah, here's the contact me information slide. There it is. Again, folks, I was just saying to a patient today, I think, really, I was saying it to this patient. She was a hip arthritis patient. She came in and she's a very active 72-year-old former competitive bodybuilder, and really didn't want to have her hip replaced, but her orthopedic surgeon friends were telling her, hey, look, don't wait, get the darn thing replaced. And she came into my office because she was thinking, well, maybe stem cells will help. Maybe I don't have to have surgery. And basically, it was one of those brief encounters where I did a physical exam and I took an x-ray and said, you know what? Your surgeon friends are absolutely correct. It'd be wasting money to try to inject this joint with stem cells. You really need to have it replaced. And she was very, very grateful. And I said to her, look, it's my pleasure. You come to see me as an expert in the field, and it is my pleasure to give you an honest appraisal. And if I don't think I can help you, I will tell you that. If I think I can help you, I will tell you that. And then I will send you a proposal in which there are, no secrets. There's no small print. It's all laid out in front of you, and you get to decide. In the privacy of your own home, we send this proposal to you via email. There is no point of sale pressure in my office, and I pride myself on that because I pride myself in being a medical doctor and not a used car salesman. Folks, it's really been a pleasure, and I really appreciate you spending well over an hour now of your time with me on a Tuesday night. Thank you so much for attending. And again, any further questions, please contact my office. If anybody would like a recording of this presentation, you can also contact my office. I think it will be available by sometime tomorrow. Thank you all very much. Have a great evening. Take care. Bye-bye.